Well, good morning, all. We'll go ahead and get started with announcements and introductions as folks get settled in. Such a delight to see everybody back for our first grand rounds of the season. Just a couple quick announcements. There are several flyers outside the door, but including this one, which is for the Roger Alberti Quality Improvement Lecture. This typically features a very prominent, nationally known surgical expert, and that will be on Thursday, October 6th, so different from our regular Grand Round series. Dr. Hassell does have handouts that will be available. They're still being printed, and so pick those up to sort of help trigger your brain later as some reminders of things that he talked about today as you leave. Next week, we'll be hearing from Dr. Allison Conlin. She'll be giving a talk entitled Breast Cancer, Answers, Advice, and Anecdotes. Today doesn't require much introduction. I'm very pleased to welcome back Dr. Miles Hassell, who many of you know. He earned his medical degree from the University of Western Australia and did his internal medicine residency here with us at Providence St. Vincent. Dr. Hassell has remained very engaged with teaching in the residency program and also is quite generous in sharing his knowledge and his passion with the community and across the region. He's frequently an invited speaker. His internal medicine practice, as you can see up here, is the Comprehensive Risk Reduction Clinic, which really emphasizes evidence-based nutritional and lifestyle management in the context of really also a full traditional medical model. He has worked as a principal investigator in a trial using nutritional interventions to reduce side effects of conventional cancer therapies. And he is also well known as the co-author of Good Food, Great Medicine, which is a guide for using nutrition and lifestyle interventions to optimize health. Without further ado, Dr. Hassell.
Thank you. Well, thanks, everybody. So, I'm going to... As most of you know, I'm somebody who believes that our lifestyle advice is the most important piece of advice that we give. And I would also make the case that probably we, as a culture, we don't give it the status it needs. So, and with respect to heart disease, we're going to talk about which lifestyle factors really matter and which ones should we not bother our patients with. I'm going to hopefully be demonstrating throughout this, just reminding us all just the huge range of benefits of lifestyle medicine compared to the other things that we give an emphasis to. And because when we prescribe somebody with a high blood pressure medicine, we may or may not reduce their long-term risk of anything bad happening in net. But with lifestyle medicine, we not only tend to reduce things like heart disease and stroke, but also dementia and type 2 diabetes and depression and frailty in the elderly and cancer. We improve cancer survivorship to a degree that's similar to that we see with most chemotherapy and radiation approaches, at least in observational studies. And I'm going to hopefully be giving you data that would help us all give patients lifestyle prescriptions that are simple and limited to those things that matter. Just a couple of data points that you're familiar with, reminding us of the power of lifestyle medicine. These are observational studies looking at patterns of behavior and outcomes. So these vaguely defined good diets, fruits, vegetables, seeds, berries, twigs, not being too chubby, walking every day, drinking some alcohol. In the Nurses' Health Study, dramatically reduced cancer, heart disease, all-cause mortality at no cost to society, arguably. They've also published data for the similar sets showing about a 90% reduction in diabetes, type 2 diabetes risk. In Caerphilly, in the United Kingdom, it's just similar data. If you did 4 of these 5 things, didn't smoke, BMI less than 25, 3 servings of fruit and vegetables a day, regular exercise, and regular alcohol intake. In the Caerphilly, of course, this is Britain, moderate was 3 or fewer drinks per day. I wouldn't recommend that, but that's what the data showed there. Dramatically less mortality, less cognitive impairment and dementia, less type 2 diabetes and vascular disease. And in Germany, the same thing. not being too, they raised their BMI to 30. 3.5 hours a week of physical activity, high intake of fruits, vegetables, whole grains, and low meat compared to the rest of the population. Not smoking, 90% less diabetes, 80% less heart disease, 50% less stroke, 36% less cancer. These are all data, of course, that would transform our society on many levels, if applied. So this is going to be in a couple of sections. One is sort of the 4 main things I think we should emphasize with respect to what to do, what should be avoided or minimized, what not to do. Necessary restrictions, we'll talk about things like beef and dairy. And I'm hoping that we'll have a bit of a discussion about how to make all this a priority. So what to choose. I'm going to talk about exercise every day, eating an omnivorous Mediterranean-style diet, aim for a waist smaller than the hips, and adequate sleep. I won't say much about sleep because that's an hour by itself. If we look at just the exercise prescription alone, which I think should, well, I'm going to make the case that most of these things should actually be part of our vital sign group, which of course would really cheer up our nurses. But if we look at exercise, huge reductions in all-cause mortality, cardiac mortality, improvements in outcomes from people who've already had MI, so in secondary prevention, primary prevention. If you look at the data, 30 to 60 minutes of brisk walking per day, it might be as good as anything that you do. There's more, we'll talk about why more may not be better. And the way we present to our patients is this idea that there's no exceptions. You should do it on days ending in Y. And we like to point out that we're not just talking about heart disease or whatever we're seeing the patient for. If I see a cancer patient, the observational data suggests about a 50% reduction in mortality in cancer patients who exercise. And if I'm looking at a depression patient, I can tell them, we can talk about your antidepressants. We can also talk about the fact that exercise is likely to be better than your antidepressant, and so on. And I love this idea of a do-it-yourself bypass we'll touch on. Then this is all these other benefits we talked about, and this will be in your handout. But to say somebody talks to me about flu shots, I say get a flu shot if you want, don't get it if you don't want. I don't really care that much. Are you exercising? Because if you exercise every day, you're less likely to get the flu to a greater degree than we can demonstrate with a flu shot, and so on. You want to live longer and better. So we don't want to live longer in a state of poor quality of life. But exercisers live longer and in a state of good quality of life. Typically somewhere in the region of 3 to 4 years longer, in somewhere around 150 minutes a week of exercise. This is the do-it-yourself bypass thing. German guy, randomized. I've presented this data many times. It's the only study of its type. That's why you keep hearing about it from me. Randomized patients with angina to a stent or exercise, and the exercise group did better. And that's what we present this as a do-it-yourself bypass, which is a little extreme, I'll acknowledge, but not unreasonably extreme. Sitting. So some of us in this room are known to sit quite a bit, and it's really easy in our profession, most professions, to sit quite a bit. And it's worth noting that sitting is as great a risk factor as not exercising, and exercising doesn't overcome the risks of sitting. So we try to recommend our patients get up and walk around every 30 minutes or so, and I try to do that too. It's interesting how if you sort of turn it into a bit of a nervous twitch, it's more successful. And it's not just because I didn't take my meds this morning. Will they do it? This was an interesting study. Once again, the only one of its type I know of, where they had 4 doctors in the clinic, and 2 doctors were habitual exercisers and 2 weren't. The 2 doctors who were habitual exercisers had their nurse, after they recommended exercise, they had their nurse call the patient up a month later. And the doctors who exercised and who did a follow-up call on the recommendation to exercise had dramatically higher rates of compliance with exercise, 70%, not shabby, right? Compared to those that did not make the recommendation and didn't get a follow-up call. And this was shown, also demonstrated in the patients who were told to exercise and had a follow-up call, also had better health outcomes as measured by BMI and HbA1c. Once again, we could to get an HbA1c down by 0.5%, we could have spent like a $5,000 a year drug with side effects. There is such a thing as too much exercise. I just find this fascinating. It looks like somewhere between 15 and 25 miles a week of running starts to be too much in terms of cardiac arrhythmias, which is, for those of us that don't like to run 15 to 25 miles a week anyway, it's enormously refreshing. So I tell people I really don't think they need to do that much. So I think the importance of exercise can't be overstated. I think we should have a conversation with the patient. I don't think it has to be a physician to do this. It should be somebody. But the physician has to draw attention to the patients, every time you see the patient, to help them realize how important this is. And I'm somebody who's a big believer in the short duration, high intensity research because, once again, it suits my ADHD personality. But your patient doesn't have to spend a ton of time. They don't need to have to spend 30 minutes walking if they'll do something short, like a short sprint, weights, that kind of thing. Exercise bike. I think we need to give a written exercise prescription. I think we need to ask about compliance, just like we do every other drug we prescribe. And although you can do excessive exercise, I would remind us all that probably doesn't need to be a major concern. I wouldn't be weighed down by the fact that your patients are going to overdo it. We don't see a lot of that. Any questions at this point? Pretty quiet audience. No questions about the fact that patients won't do it?
One question about age.
Yeah.
And vigorous exercise. How about your geriatrics, like 75-year-olds plus, and walking, running?
There's some people in here that may question whether 75 is geriatric. I just thought I'd mention that. So we don't have any limits. So I've got a 92 or 93-year-old guy who just got a TAVR. He spent 30 minutes on the heavy bag. Now, this guy was a light heavyweight champion of the Marine Corps in 1945. So he wasn't your average kind of guy. But he would work out on the heavy bag for 30 minutes a day, right up until the last couple of months. And hopefully he'll get back to it now that he's had his TAVR. So I don't see any reason to stop exercise at any point. But we always find out what they like to or can do. That's our critical detail. If all they can do is walk to the post box, then we ask them to walk to the post box 4 or 5 times a day. I just got a guy, he's got bad peripheral vascular disease. And I said, well, you got to exercise. And he said, I walk half a mile and my leg hurts. I can only walk half a mile a day. And I said, no, you can walk half a mile 4 times a day. He said, I do have other things to do. And I said, how about scheduling your amputation? Once again, a little dramatic, but it worked. Did I answer your question? Oh. All right, so let's talk about the Mediterranean-style diet. So, generally speaking, in most observational studies, reduction in total mortality, heart disease and stroke, dementia and Parkinson's. In fact, the neurodegenerative benefits arguably are the most prominent part of the benefit of the Mediterranean diet. Longer survival, less type 2 diabetes, less depression, and so on and so forth. And we don't know how much is really related to the Mediterranean-style diet or just a whole food diet that's been studied well. Here's a couple of randomized controlled trials. So the last slide was observational data. This is randomized controlled trial data, secondary prevention trial, the Lehman heart study, reduction in cardiac events, deaths, and all cancers. PREDIMED, a randomized control primary prevention study showing reduction in stroke, heart disease, less breast cancer, less diabetes by about half over 4.7 years. So reasonably strong data, both from observational and randomized control trial data perspective, and certainly superior to any other dietary pattern that we have evidence for. What are the mechanisms? We could go on and on about this, but the main ones have been highlighted. It's anti-inflammatory, it's immunomodulatory. You get higher blood levels of antioxidants for reasons that are not entirely clear. Less cholesterol oxidation may be a big deal. The good fats, the people that did the PREDIMED study, their big thing is the olive oil, and we'll talk about that in a second. One of the interesting things about the Mediterranean diet randomized controlled trials is they emphasize homemade food and reduction in preserved meats and pastries. And this is often not really noticed in the assessments of this, that in their methods they really emphasize homemade foods. And that might be a much bigger factor than we realize. Another thing to note about the Mediterranean diet studies is they exclude weight loss or exercise as components. These are designed to look at just the dietary factors alone. So any weight loss and any exercise benefits are in addition to. The DASH diets certainly have good, and this includes DASH diet with high-fat dairy or with red meat or without, have certainly promising short-term data for benefit that may well be as good as Mediterranean. Nordic diets have been studied. Observationally, those look good. Pan-Asians look good. My bet is any whole food diet with limited refined carbohydrates and a lot of fish and plants is probably going to be good for us. So I wouldn't get all bent out of shape over the word Mediterranean. So what we're talking about is a lot of fruits and vegetables. And we'll talk about why we minimize smoothies and juices in a second. Beans and legumes, raw nuts and seeds, minimally processed whole grains, extra virgin olive oil. We'll talk about why that stands out. Fish, but not excluding other animal proteins. Historically, people have had more cultured dairy, yogurt, kefir, cheese, rather than milk. It includes moderate alcohol. It's important to remember this is not a diet that's low in fat or saturated fat or cholesterol. And the fewer restrictions we can give our patient, the easier it is for them to comply. The vegetable and whole fruit, so one of the suggestions that we make to our patients is think of their diet as a vegetable or whole fruit to which they add something. So a snack is a vegetable or whole fruit to which they add something. Their meal is a vegetable or whole fruit to which they add something. And when they flip around their thought process like that, then the proteins become added because that's what we need to be satisfied with our food. And everything else needs to be added, but it means that they're really keeping the fruits and vegetables as a dominant part of the diet. Our patients tend to have BMIs of greater than 25. And smoothies have this reputation as being these health foods, and we continue to encourage our patients not to use liquid calories because a healthy smoothie is a great way to put on a waist. Whole grains. I don't know if this is apparent in your practice, but in my practice, whole grains really have a bad reputation among a lot of our patients. They're told that gluten will kill them, and grains are generally bad. And this is coming from a couple of directions. One is coming from the anti-gluten part of society, and it's coming from the Paleolithic diet group. In actual fact, whole grains are consistently, I think one of the most consistent findings in all the diet literature is the consistent finding of substantially lower rates of total mortality with whole grains. And the total mortality reduction is right across the whole range of potential diseases, stroke, heart disease, cancer, infectious diseases, and type 2 diabetes. So I think we really should push back against those that tell us that whole grains are bad for you. On the other hand, minimizing refined grains makes good sense, and we'll talk a little bit more about that data. And we really push legumes or beans. So I encourage our patients to have a whole grain or a bean every day, at least one. Extra virgin olive oil. Another key component of the Mediterranean diet models that have been studied. And the number of mechanisms that are in play with extra virgin olive oil, I won't go through all of these, is striking when you compare it to any other oil that's recommended. So if you find yourself saying, oh, olive oil, canola oil, use something that's halfway decent, I think you're overlooking the fact that none of the other vegetable oils have anything like this degree of benefit. None of them. There's a lot of interest in coconut oil right now. It might be great. It's been used for thousands of years. It's probably fine. But we have zero evidence that it actually improves health outcomes, as far as I'm aware, compared to what we see for extra virgin olive oil. A couple of fun things about extra virgin olive oil is that people who eat more of it have higher resting energy expenditure. And they tend to be more active, and we don't quite know why that is. And the other, I'll just give you the forest plot on the cancer risk reduction, because this is one of those things that's, I think, often overlooked, is that when we're talking whole foods, we're not just talking heart disease. In this case, olive oil, over about 23 studies, looks like it averages about, those who have the most olive oil compared to those who have the least, appear to have about a 40% less risk of incidence of cancer, all cancers. And down here you can see them split out for type of cancer, and for most of them you'll see a significant reduction and a trend for all of them for reduction in
Is there
cancer.
more than one kind of extra virgin olive oil? If you go to the store, the prices can vary quite a bit, and they always say extra virgin.
Yeah, so there's probably real extra virgin olive oil, and then there's probably mafia extra virgin olive oil. And so that's the problem. So we suggest people get domestic, like California or Oregon, olive oil, because who knows what's coming out of Europe. So unless you've got an uncle in Greece sending you olive oil, then I would suggest you stick to the domestic stuff, because it's really hard to tell if they've cut it with other oils. Apparently,
Is enough or too much?
there appears to be no upper limit. In the PrediMed study, they actually gave people about 1,200 calories a day worth of olive oil. They gave them a liter a week, and so. No, we assume they didn't use all that, or they fed it to their family or something. But there appears to be no upper limit, which is really odd.
So in terms of olive oil versus the other oils, what evidence for the other oils exist? Is it just that there isn't a lot of research on the other oils versus olive oil? Or is there research on the other oils and it doesn't show the benefits that olive oil does?
Yeah, so there's quite a bit of research on the other oils, and it falls into two categories. One is research that's been done is in terms of taking oils and replacing saturated fat in the diet with oils, and I'll give you two of those experiments. And the other is just short-term studies that don't have useful outcomes, that are looking at just changing lipid levels. What we don't have is any evidence of benefit in terms of long-term outcomes like we do for, or mechanisms for that matter. Did I answer your question? And I've got another slide that's going to give specifics to what I just said on the other vegetable oils, but it's remarkably little. Claudia.
So what do you dip in your oil? Because I have to say there's nothing like crusty French bread.
Yeah, so crusty French bread for me is a treat, and so I would happily dip crusty French bread. But, would that happen once a month? Twice a month? Something like that. Not a lot.
Once a week.
Yeah. Once a week is probably, especially in somebody who's slim and exercising and doesn't have to worry about the caloric issue, then I would say once a week or more would probably be fine. And certainly I had a patient just come back from a very healthy time in Greece, and he was talking about how much crusty Greek bread was being stuck in olive oil there with all these thin, active people. So I think there's a lot of individual variability, and so if you're doing well and healthy, great.
Avocado oil?
Just using it as our main kitchen oil, then isn't that the point?
Yeah, we're talking about main kitchen oil, not hedonism, Claudia. Avocado oil. Most of the oils, like avocado oil, we have grapeseed oil. We have virtually no data, and the main data, oddly enough, we have is the safflower oil, because the older studies were done with those, and that's what, in relation to the gentleman's question from the back, that's what I've got some slide coming up.
And maybe related to Chad's question, I feel like in the lay press in the last few years, there have been at least some opinions and suggestions that olive oil data has been inflated, maybe poor studies and whatnot. As somebody who is close to the evidence, this would suggest that you still have found well-founded evidence specifically to olive oil.
Yeah, so whenever we're dealing about diet evidence, the diet's evidence is always shaky. I mean, look at the problem we have with drug studies. And it's even worse with diet because there's so many more variables. And like in the PrediMed study, how much olive oil did people actually use every day? We don't really know that. What we do know is what is better and what is worse. We don't know really how solid all this data is, frankly. I mean, there's so many variables. But we do know about the consistency of the data. In other words, the trend. Let's look at this one. Each of these studies could be criticized. They're all observational studies. Higher consumption of olive oil compared to lower consumption of olive oil. But when you see every single study trending in the same direction, that's pretty positive. And this might be as good as we get with diet stuff. So I agree, every study can be criticized, especially diet studies. But when you see a very consistent finding and you don't see the competitive ideas being any better, right? So just because an olive oil study could be criticized doesn't mean you automatically accept all canola oil, and I'll tell you why we shouldn't in a second. The canola oil studies would have to be at least as good in order to be competitive.
What about the concept that the people who follow the dietary are enthusiasts for health generally, and that it's some combination
It's a marker.
Of following the diet and some enthusiasm for their health and concern and willing to do all the other little things, whether it's not sitting or whether it's how much they exercise or all of the good things that you've mentioned. What are the writings and thoughts about that?
Yeah, because each of these things is certainly a marker for good choices. It's a little bit like churchgoers tend to be healthier. They're less likely to be drunks. They're less likely to, they're more likely to have a culture around them. There's all kinds of reasons why that might be the case, regardless of what church they go to. So I completely agree. These things are markers of good choices elsewhere as well. But even in the randomized controlled trials where they're taking a low-fat diet most commonly, compared to a Mediterranean-style diet, the Mediterranean-style diet does better. And these are in the same population, same regions. So I think because we have randomized controlled trial as well, I think that supports it. But what you're saying is absolutely true. I mean, we all can look at our patient population and see people who make mostly good choices and mostly bad choices, and the patients in the middle often are relatively small. It tends to be biphasic. So nuts. A lot of my patients are worried about eating nuts because they're high in fat and they think they'll make them chubby and stuff. In actual fact, the association of nuts with better health outcomes and probably oil seeds, things like sunflower seeds and sesame seeds and pumpkin seeds and so on, are pretty strong, very consistent, and so I'd recommend that we just make this part of our standard dietary recommendation as well. It also helps lower cholesterol. And if we looked at, for example, walnuts in the breast cancer data, it looks like walnuts help with both breast and prostate cancer survivorship as well. They also make a great core of any snack food. So an apple and a handful of almonds is a very, very substantial low-cost snack that beats a Lara bar hands down. Chocolate continues to be supported in literature. It's got mechanistic data saying that this stuff works. It's got outcomes data saying it works. We don't know how much you should have of it. Our guess is maybe out to about an ounce of the high-powered stuff. And people who say, I can only eat milk chocolate, we tell them to take a dark chocolate square, and we demonstrate this in the office. If they say they can't eat dark chocolate, we slap some dark chocolate in front of them with something else, like some nuts or a banana or something. And they always act pleased. Of course, the fact that I'm standing over there with a baseball bat may have something to do with it. But chocolate is one of those things that reminding people that we're not just trying to restrict them. We're trying to help them become healthier, not helping them become like monks. Caffeine. This is something else. So I have patients come in, not every day, but frequently, who say, I've been put on an anti-inflammatory diet. And I say, what's an anti-inflammatory diet? And they say, I'm off gluten, and I'm off caffeine, I'm off alcohol, and I'm off dairy. And I say, but all four of those things are actually associated with less inflammation. And they just look at me blankly, because what do I know? But anyway, coffee is associated with lower rates of death. Tea probably is as well. The data are not as strong. Oh, good. Here comes some coffee.
Sorry, that wasn't planned.
Right on cue. Isn't that great? Less aging, and incidentally, it lowers inflammatory markers as well. Recent study, it was really fascinating. They had substantially less progression of, that's misspelled, sorry. For substantially lower rates of progression of Parkinson's disease in people who had, I think it was 3 to 6 cups of coffee a day, compared to the people at the same stage who didn't. These were all patients, newly diagnosed Parkinson's patients without any medications. And the time to need medications was much lower in the coffee drinkers. So let's keep drinking coffee and tea. We're big on fish, associated with longer life, lower total mortality. It really stands out compared to other animal proteins in that way. Fish oil supplements continue to look like they don't do much. So we use fish oil supplements very rarely. Any questions about fish? Worried about mercury? No? Move on.
Only when I was pregnant.
Okay, all right. Okay. Um,
There's a study that's just come out with 12 grams of EPA that suggests that does have benefit. Does that have any relevance to this case?
yeah, maybe if you got up at 12 grams of EPA, that's a ton of fish oil. Yeah, they probably were, because there was a jealous study a long time ago, Japanese study on just EPA that had pretty good results that didn't sort of pan out with all the other fish oil studies, so it kind of got ignored. But maybe we just need to push it higher. But boy, that's a lot of.
The compact pills.
Yeah, if you had distilled it, you could do it but it's still going to be 12 grams. It's still going to be 12 big honkin' capsules, or 24 smaller capsules. It's still going to be a ton.
Is there some studies suggesting high intake of fish oil might be associated with increased chance of prostate cancer?
Yeah, and yet we also see lower rates of prostate cancer death in people who eat more fish. So the prostate cancer data and omega-3 fats is really mixed up. I can't find any single trend in the literature. It's all over the place. But I think it would be another situation where you wouldn't use fish oil in that population, because eating fish seems to be beneficial for prostate cancer. And this fits into my whole bias favoring whole foods anyway. Fish oil is a rich person's first world solution, whereas fish is something that almost everybody has access to who's near a coast. Alcohol continues to be associated with lower rates of total mortality, heart failure, heart disease, primary and secondary prevention, lowers risk of type 2 diabetes, lowers risk of diabetic complications in people who have diabetes. If we can figure out how to keep people from drinking too much, we should still, I think, have people drink alcohol. Now, the mechanisms, once again, numerous. I like this one. They gave IV alcohol to pigs, and their collateral blood flow improved. I think this is the only animal study in my whole talk, but it was just too much fun. So numerous mechanisms for benefit, but I don't know how we get around the public health concerns of people drinking too much.
Do these benefits pan out for folks with aldehyde dehydrogenase deficiency?
Oh, I don't know. I should know that. Does anybody here know whether these benefits apply in people with impaired alcohol metabolism? I haven't seen anything on that. Yeah. Oh, yeah. You're in the dark, you see, so you have to wave.
Yeah, Miles.
Hey, Tim.
The risk of dying of any cause, and focusing on women, particularly one drink of alcohol. Just a minute.
I'm glad you asked. Okay. Tim just set up my next slide.
Okay.
So you're concerned that we should make a different recommendation for women?
Yeah.
Yeah.
If you go to UpToDate, it talks about the relationship between breast cancer and women who drink. I'm assuming when you make this statement here, you're also recommending very strongly that these women should be taking at least 300 micrograms of folic acid a day.
No, actually I don't. I recommend they eat a diet high in folate. And we actually have a handout.
I'm talking about particularly women who drink even small amounts of alcohol per week. If
Right.
you look up UpToDate, it's really impressive.
Yeah. No, I agree. And so then that's why we concentrate on total mortality, first of all. And secondly, do those women who drink and have a healthy diet have increased risk? And that's where this study is really helpful. So first of all, for women, it doesn't take that much alcohol. So 3 to 7 drinks a day per week is a reasonable recommendation. Note the correction. It makes good sense, even from the breast cancer perspective. Because until you get to somewhere around a drink or more per day, the risk associated with alcohol is very, very low, and arguably within the range that you can't really make any sense out of an epidemiologic study. And then you go down here and look at this. So I mentioned the article here and also a fabulous editorial associated with it that really talks about women with breast cancer or at risk of breast cancer, both groups are talked about, and their alcohol intake. Just a fabulous big study and really, really worthwhile, written by heavies in the field. So I would argue that the total mortality and heart disease risk reduction is enough to allow us to recommend it to women who aren't at risk of over drinking too much. that certainly keeping it to less than 7 a week makes good sense. That certainly maintaining a high folate intake in their diet, which is not hard. We actually have a handout that we give people just on folic acids to tell them how they can get plenty of folate in their diet. And we can even with confidence, I think, recommend it to women who have breast cancer, because a woman with breast cancer is more likely to have heart disease than she is of her breast cancer, by a long way. And so that's what makes this study, I think, so valuable from JCO.
Miles, does the type of alcohol matter?
It may not. The study I'm using on this is actually a huge epidemiology survey from 1996, believe it or not, 20 years ago. I haven't seen a better one come out. But boy, you just see this consistent dominance of red wine in the literature. And that could be due to two things. One is red wine might be better, and that's my suspicion. It also could be that the red wine growers and creators are much better at doing studies, and there's a good basis for that too.
I just like to comment, all the national cancer organizations recommend, or have there's recommendations about alcohol. The American Institute of Research, and they don't recommend it.
True, but are they right?
I don't know, Miles, but I just think that's important to know because the consumers are getting that information, and so it gets
True, and that's why we'll talk a little bit later about the problem of eminence-based medicine instead of evidence-based medicine. And I think it's a real issue. The public health authorities are scared to death of alcohol for good reason. We're talking to one patient at a time and saying what is best for this patient in time, not what's best for a public health recommendation. And I think there's a huge difference between that. But I think we have to really question, and we'll talk about salt in a second if we have time. We really have to question our authorities. Are they accurate or not? They don't have a great record, I would argue. So waistline, tough area. We could spend an hour on this one obviously as well. But remembering that excessive abdominal fat drives pretty much all of our cardiac risk factors. And we've got to have a plan for our patients that if they want to, where we help them think about their motivation, give them sources they can go to about the food choices, food quantity, daily exercise, all the things that will help them control their waistline, and not let it slide any more than we'd let the discussion about their high blood pressure slide or their high blood sugar slide. Adequate sleep. You'll notice this is empty. I didn't know where to start. I think the data shows that sleep is really important. That it's mostly a lifestyle choice in terms of how people are choosing to spend their time, especially with respect to entertainment. But that there's also this big problem of insomnia. So we have a couple of pages in our book about this. But I thought it would consume this whole talk if I went into it. I did not want it to not be mentioned with respect to heart disease. Some things I think we should avoid. Refined carbohydrates, I think, have reasonably strong evidence for harm for heart disease. Hydrogenated oils and trans fats. These seem to be much less an issue now, so I won't spend much time on that. I'm going to talk a little bit about the highly processed vegetable oils that the gentleman back asked about earlier. And I'm going to touch on whether we should worry about unnecessary restrictions. And this is the health world according to Miles. So obesity and dietary sugars and starches and inactivity and insulin resistance all are driving pretty much everything, which makes my world much easier if I just concentrate on these things. But just thinking about dietary sugars and starches, they drive much of obesity. They're significant contributors to hypertension, significant contributors to hypertriglyceridemia. And I keep seeing patients with triglycerides of 700, and I see that they've been told to go on a low-fat diet. And I would submit that that's not how we should treat hypertriglyceridemia. We should get them off the refined carbs. Ischemic heart disease and stroke, we'll touch on that data. Insulin resistance, of course. Even things like dementia, and I think we can make a fairly strong case on the contributing factors, how refined carbohydrates contribute to cancer. Couple of pretty good-sized observational studies suggesting added sugars, as well as refined grains, both contribute substantially to heart disease risk, as well as risk factors of heart disease like metabolic syndrome. This was a slide I dug out of my archives. This is from 2011. This is from an ACC presentation, and thanking the Coca-Cola Company, General Mills, and Subway for their support. And I don't know if you remember that Providence, Portland was going to put in a Subway a year or two ago, and then that disappeared. I don't know whatever happened. At least as far as I know, it never did. But these are all major donors to the heart disease world, and also to the supply of refined carbohydrates in our society. And that leads to some, there's not like a good conspiracy. Conspiracies are so much fun. But in this week's, the journal formerly known as Archives, has a couple of discussions about what would appear to be something approaching conspiracy in terms of the heart disease world being manipulated somewhat by the refined carbohydrate world. And I would not be surprised if that is correct, but I think it's, ever since Yudkin was talking about this back in the 50s, a British guy, and he wrote a book that was a big in my kind of world back in the 70s and 80s called White and Deadly, I think, something like that. Anyway, but he was always sort of pushed aside in favor of the, so he was saying basically heart disease is a sugar problem and white flour problem. And he sort of lost out in the discussion and the debate to the people that were saying it was mainly a fat problem. And I think the pendulum is swinging, and I think time is going to show that he was right. Artificial sweeteners.
Back then, as I remember it, people weren't eating as much sweetened beverages as they were. They were eating a lot of Crisco and a lot of lard, and people had bacon on, bacon fat on the counter. So I think that was part of a cultural phenomenon too, just from the volumes. If you look back at the old sugar data, people weren't consuming as much then.
No, they were drinking a lot of eating a lot of white flour though. So he was making the case. Remember, he was making the case for this in the 50s. But I agree, it certainly got worse.
Sugar lobby is hugely powerful.
Yeah.
Huge for a generation.
Yeah, or two, yeah. But what these guys are saying is that the sugar lobby has heavily influenced our thought leaders. The data for artificial sweeteners continues to be really mixed. But the idea that people who eat more artificial sweeteners tend to eat more overall, I think continues to be an issue. The number of studies showing that people who habitually use diet sodas, in this case, if they drank diet sodas every day, they did worse. If they drank it only a few times a week, it didn't make any difference. We've got a few mechanisms. Swithers talks about how the brain relates to calorie intake when you have a lot of artificial sweeteners. This study looks at the effect on the gut microbiome and how that might affect glucose tolerance. So my biggest case against artificial sweeteners is it maintains people's sweet tooth, however. It maintains their desire for more sweets. So I think we can make a reasonably strong case, but certainly not ironclad case against artificial sweeteners. For no other reason than it maintains a habitual intake of sweets. If we believe this data that sugars are a problem, we've got to be good at identifying for our patients what is sugar. So for a long time, for example, agave nectar, which is just high fructose corn syrup with some gussing up, was really being promoted by the health food industry for a long time, maybe 8 or 10 years, I guess. And they seem to be backing off on that now. But if we aren't informing our patients about what refined carbohydrates are, who is? And it's not going to be somebody with their health in mind, I would argue. I think a case can be made with respect to the sweet drinks, including juices, as far as a risk, especially for diabetes and metabolic syndrome, but also high triglycerides. And minimizing refined grains, basically anything made with white flour or white rice, which are pretty much pure carbohydrate. There's really no useful nutrition in those products, and they're really easy to overeat. Although we will give Claudia a pass, I think, on the white bread and olive oil. So now we're getting to the slide that I'm hoping may address some of the issues in terms of olive oil versus other vegetable oils. So if we think about vegetable oils, you're thinking about canola, soy, safflower, peanut, corn, whatever. This bland, clear, relatively tasteless source of calories. Does it have anything else in there except calories? No. Because it's been purified to such a huge extent, even if it says cold pressed on it. and so I phoned up Spectrum a little while back. So they're a big supplier of cold-pressed oil, and tried to get them to answer this question of how hot do your oils get during processing? They would say, well, they're cold-pressed at less than I can't remember what. And I said, yeah, but I'm not asking the pressing temperature. I'm asking what temperature do they reach in all stages of processing? Because I knew they would have to give me an answer of this in this region, and they wouldn't give it to me. So you get these oils that are processed at very high temperatures. Now, in contrast, extra virgin olive oil, if it's done according to the rules, isn't pressed at more than 80 degrees Fahrenheit. So they can't even press it on a hot day. And you get these bland, stable, and nutrient-depleted oils. These are not oils that have a rich source of nutrients, unlike extra virgin olive oil, which may explain why the data are so divergent. And then these two studies are really interesting. So these are both old studies that were recently, there's this guy, a British guy called Ramsden, who's taken a real interest in this because he thinks these oils are really bad for you. And he's got this, if you read this paper here in the BMJ from 2013, he has a big discussion in the supplement over how these highly refined linoleic acid can cause LDL oxidation and actually increase the risk of heart disease, which in both these studies, the Sydney Diet Heart Study and the Minnesota Coronary Experiment, both the substitution of saturated fat with linoleic acid in the form of safflower oil was associated with a higher death rate. And he went back and got the data and demonstrated this. This was not part of the original publication. So once again, I think we really have to be cautious about who's telling us the truth, whether it's a China study or any other study, because it may be what we aren't being told that's part of the problem. So I would argue that we can't really find data saying we should be using these modern, highly refined vegetable oils. Virgin coconut oil is probably good, and I only say that because it's been used for thousands of years. It's hard for me to argue against something that's been used by half the world for a long time. And of course, anything fresh pressed from seeds or nuts, if you see it, but this stuff's horrendously expensive and really good for dipping crusty French bread in. So it's not just olive oil. Incidentally, I don't know if the gentleman who asked the question about the vegetable oils is still here, but did that answer his question? You had to go around. Oh, okay, rats. Well, I hope I answered his question.
What about raw almonds and raw walnuts compared to toasted or something like that?
Yeah, so when you toast a nut, so nuts, about 80% roughly of their calories are in the form of fat. When you roast them, then that fat starts peroxidizing to a higher extent, to greater extent, more rapid extent, creating oxidants than it would if it was in the raw form. So we recommend against roasting unless you're going to roast it yourself. There's another reason not to minimize roasted nuts, and that is they taste way too good. And with nuts, the dose isn't a really issue. It's really easy to get chubby on nuts. They might be good food, but too much good food is still too much. So we would encourage raw nuts unless you're going to roast it yourself. The idea, when you roast it yourself and hopefully eat it relatively close, then it doesn't have as much time to form all these oddball oxidation products. So I'm arguing the things that don't cause heart disease: dietary cholesterol and saturated fat, eggs, dairy, red meat, and salt added to homemade food. So this is where I may cause more consternation, so feel free to yell. This is a really interesting meta-analysis that suggests that the saturated fat in the diet, just in normal foods, is not associated with mortality, cardiovascular disease, heart disease, stroke, or type 2 diabetes. But as we've seen consistently, trans fats from hydrogen oils can, I think, have a very, very consistent association with harm. So we recommend our patients avoid hydrogenated oils and avoid highly processed vegetable oils, but don't be too fussed about naturally occurring sources of saturated fat. And I'm going to mention some specific foods in a second: beef, dairy, eggs. And for those interested in this subject, this paper and the associated editorials from 2010 from the AJCN is really a fabulous overview as well, partly because there's 3 editorials giving 3 different perspectives on the data. And you just get this wealth of views. And I highly encourage anybody who has an opinion in this area to make sure they're familiar with that. This is a paper suggesting that circulating saturated fat, the markers in the blood reflecting saturated fat don't seem to be associated with heart disease either. And then these papers look at the refined carbohydrate in the diet compared to saturated fat in the diet and say, even if saturated fat's a problem, refined carbohydrates are so much more of a problem that they should be our focus. So dietary cholesterol in eggs. So eggs have maybe 200 milligrams of cholesterol per egg, something in that region. And it's worth looking at this data. This is 1,000 men followed for 20 years in Finland. Couldn't find any associated with the health outcomes. I like the fact that they're an excellent source of nutrient-rich grow-your-own protein because I have 5 chickens. So I have a bias with this. This is 7,000 people. This is the PrediMed subgroup. 7,000, they looked at people who had more than 4 eggs a week compared to those that had less than 2 a week and could see no association with any health risks. And this was an interesting study. They took people and gave them either 12 eggs a week or less than 2 eggs a week and could find no association with any adverse effect on blood markers. This was a 6-week study. This was 4.7 years. This was 20 years. Dairy. Mixed data, but all the data seems to be either neutral or weakly positive in terms of total mortality. There are some studies suggesting if you have more dairy fats in your blood, you actually have lower rates of heart disease, especially for women. This is that study. A pretty consistent association between dairy and improvements in insulin sensitivity and lower risk of diabetes. There's 8 studies looking at inflammation in dairy. 4 are neutral, 4 are positive. In other words, show an anti-inflammatory effect. Part of the problem with the dairy data is that some of the investigators stick ice cream and puddings and flans in with the high-fat dairy group, which really messes up your data because ice cream is not dairy. And so we would recommend avoiding dairy with added sugars and emphasize cultured dairy. And we think the evidence is pretty strong for, at worst, neutrality and probably benefit.
Well, you don't mean to say ice cream is not dairy. You mean to say maybe that ice cream is not a whole food dairy product.
Yeah, ice cream shouldn't be lumped in with dairy products in terms of health outcomes. My Rocky Road is not going to tell me whether dairy foods are good for me or bad for me. What was the question?
I was asking whether or not it's because of the added sugar in ice cream that confounds the data.
Oh, sugar, all kinds of, ice cream's a wealth of chemicals in most cases, emulsifiers. And so it'd be a little bit like comparing Yoplait with real yogurt. Yoplait is pudding. It barely qualifies as yogurt in any sensible world.
Even low calorie?
Even low calorie, even the low fat, even the fat free, especially the fat pea.
What about almond milk?
So I call them fake milks. So if you make your own almond milk, in fact, there's a guy recently, he said, look, I let my patients have as much ice cream and pies and stuff as they want as long as they make them all themselves, which probably works. So if you're making your own almond and soy milk, dandy. But remember, when you make almond milk, you get this stuff, and it can be done well, although it doesn't taste great. It tastes a lot better if they doctor it up a bit. And then you've got this mass of stuff you're throwing away or giving to the pigs or something. And that's where all the real nutrition in almonds is. So I can't see a place for almond milk or soy milk or rice milk or barley milk unless the patient is milk allergic. I can't see any benefit of it.
What about coconut milk?
I don't know much about coconut milk. I've not seen any studies. I haven't found any studies on it. And it seems to be quite heterogeneous in terms of what people are actually talking about. So I don't know if you can inform us.
No. I'm just curious because I don't do any of them, but I'm always
Yeah.
curious about them.
Yeah.
It's a great ingredient for cooking. Not so much for drinking.
But coconut milk, even defining what it is. I grew up, coconut milk was coconut water. The stuff you poke a ice pick in a coconut and you get the water out. And that was what I thought was coconut milk, and obviously I was wrong. And then we use coconut milk in some of our recipes. But I don't know about any health benefits. But boy, it tastes good. Red meat, bad or good? So first of all, this is a great area. Like so many areas in diet, you can really pick the result you want. The one result you probably can't pick is processed meats. I think the studies are pretty consistent with processed meats. I like to remind everybody that it's a traditional food. It's a rich source of lots of different nutrients. And if you look at observational studies, in a lot of the studies, arguably the majority of the studies, high meat eaters have a higher mortality than low meat eaters. That's kind of uncomfortable for meat eaters like me. But then this is an interesting example. This is a fairly recent paper from the archives where they said, if you were healthy and you ate meat, it didn't seem to make any difference to your outcomes. If you're unhealthy, in other words, by unhealthy, they said obese or smoking or sedentary or excess alcohol, those people, if they ate meat, had a higher mortality, which is kind of odd. And then you get this group of studies, and I'll show them in a second, where if you take red meat and add them to a healthy diet, in bold they took a DASH diet and added red meat to it, you actually show improvements in metabolic risk markers. So that's kind of interesting. And then, most compelling to me, is if you look at these omnivorous diet patterns that include red meat, they seem to have better results than diets without red meat. So it might be the pattern that's important and not eating too much red meat. And the AICR come up with a 1.5 pounds per week maximum of measured raw of red meat a week as being a maximum safe from the cancer perspective. And that's probably a reasonable guess.
Why are ham and bacon different than steak?
I wish I knew. I don't think we know why ham and bacon are a problem. But the preserved meats, and we also don't know whether traditionally preserved meats, which were cultured, are better than the chemically preserved meats that we have nowadays. Or there's a lot we don't know. In this case, it was a Finnish study. They looked at men who ate red meat, and they had made a lot of poor choices. They ate more poorly, were more sedentary, more likely to smoke, and so on. So that's a confounder as well. We're running out of time, but just so you know, when you actually look at red meat in a randomized control fashion, in the context of an excellent diet, you don't see any harm and you see benefit. But these studies have a lot of different confounding variables. So the real study we'd love is a good diet with red meat compared to a good diet without red meat, and we don't have that, and probably never will. So omnivorous Mediterranean diet with moderate red meat so far gives better health outcomes than any other approach that's been tried. And I'm not aware of any long-term prospective studies simply looking at red meat. This is in the handout, a little discussion about how we view vegetarian and vegan. Data just aren't as good for benefit, however you cut it. In fact, the benefit for vegetarian diets may only be seen in the Adventist population. Salt, this is another real flashpoint. Most people don't follow a low-salt diet anyway, which might be beneficial, which might be preferable that they ignore the authorities, because multiple studies, now these are all studies that have reason to criticize them, but where is the good study that shows that low salt is good for you? I think we struggle with that, because this is a meta-analysis of 25 studies showing that low salt being harmful. This was where is it? This most recent study in The Lancet, it took 4 of the best studies on salt and showed higher mortality in those that had low salt diets, including people with congestive heart failure. So I'm failing to see where the data are that show us that a low salt diet is good for you.
But they've taught us that for many years.
Right, yeah. And but the importance is, if you're asking people to make their food at home and enjoy whole foods, if they're not able to salt it, it's not going to taste very good, and Taco Bell starts looking really good.
Miles, pardon me, but isn't that what, and maybe I've got it wrong, isn't that what the DASH diet is? So they encourage you to try that, and it's terrible.
Yeah.
2,000 milligrams of salt per day.
And it's tasteless.
It's what?
Early death might seem like a preferable alternative.
It's tasteless, but in terms of lowering hypertension, yes.
True,
It does.
but any high vegetable diet, because I think one of the things that's forgotten is that if you eat more food at home, you're going to be getting more potassium, you're going to excrete more sodium, and this might be a huge confounder that we're not taking into account.
Yeah, but you're saying that there is no studies that show that a low-salt diet is beneficial, but so you're saying that the DASH diet...
No, DASH diet helps reduce high blood pressure, but why? It's got low-fat dairy, that lowers blood pressure. It's got lots of vegetables, that lowers blood pressure. I'm arguing any diet with a lot of vegetables is good for you, including the DASH.
Nothing to do with it in the DASH diet.
Probably a fairly small amount. It does have some, but does it change? It doesn't have any effect in changing outcomes, because so far we're not seeing the same degree of improvement in health outcomes from the DASH diet as we do from the Mediterranean style diets that don't restrict salt.
In Mediterranean countries where they, I assume, primarily eat a Mediterranean diet, is their lifespan
Actually, they don't.
any different than Western countries?
Well, they actually don't consistently eat a Mediterranean diet there. So the Mediterranean diet we have now is sort of a construct that's not, apparently it's not all that widely followed anymore, because they've got Kentucky Fried.
The Japanese and Koreans have 2 to 3 times the sodium intake that we do, and they live longer.
Yeah, and that's the confusing part and it really casts doubt on whether we should be eating a low salt diet. Yeah. So, two final slides. Are we convinced of the importance? I think we need to be asking about this stuff. We need to have evidence-based resource for our patients. We need to avoid unnecessary prohibitions. We need to prescribe, I think we need to prescribe lifestyle with the same urgency as we prescribe our medicines. If non-compliance with a statin is a problem, why isn't non-compliance with exercise or diet? And I don't think we can be discouraged by non-compliance with lifestyle any more than we are non-compliance anywhere else. I think it should be a dominant and universal part of our healthcare system. I don't. This is not a joke coming from me. I think lifestyle metrics. We should create some kind of vital sign. First of all, we'd have to agree on something, and we can do this. If we can put in a TAVR, and if we can adopt ICD-10, and if we can put in EPIC, we can jolly well make lifestyle a more dominant part of our healthcare. Thank you.
Anyone with questions, feel free to chat.
Thank you.